On. All right, guys, we are going to go ahead and get started picking up where we left off. We ended on slide 21, so this is going to start on slide 22. Today, what we're really going to be getting into is the nitty-gritty of the nursing diagnoses. A lot of what we're thinking about here, right, remember, is how to organize our brain. So how are we going to put this into something that makes sense, something that we can use for our patient? A lot of what we are doing when we are doing nursing diagnoses are going to be either, in this class, we're going to focus on actual nursing diagnoses or risk for nursing diagnoses. So an actual nursing diagnosis is when we know that there's a health problem. This is usually what why they are seeking care, why they came into the facility. You are gathering information on this during your assessment. This is what you're gathering data on when you're doing your assessment on your patient when they come in. This is identified current health problems. All right, so our risk for diagnoses are going to be our risk management. So these are situations where we can reasonably predict that harm could come to them as a result of something based on what we know. So this is the interpretation of our assessment data. Think safety issues with this one, right? So risk for things are safety problems. So risk for falls after orthopedic surgery. For an actual diagnosis, it could be impaired gas exchange when we know they have low oxygen saturation. All right, we are going to walk through NANDA diagnoses while we go through the rest of this PowerPoint based off of our flat John in our presentation. So a couple of other aspects of nursing diagnoses we have our health promotion. When you think about these, think about our Maslow's, right? So health promotion, these are going to be, we are wanting to move towards a better level of health from how they showed up. So if we have a broken arm and the patient is not able to toilet independently, the alternative is me helping them to toilet, me helping them to pull up their pants and wipe their bottom, whatever it might be. We want them to move towards a readiness for enhanced self-care, right? That would be a good nursing diagnosis for this patient. Readiness for enhanced self-care. They want to be able to be independent in their hygiene practices. A syndrome diagnosis. Some diagnoses, we actually have some diagnosis authority over syndromes. So we can recognize symptoms of PTSD, but label it as post-trauma syndrome. So another example here would be disuse syndrome in a stroke victim. So if we have a patient come in with a post-stroke and they're actively neglecting or not using that limb, we could diagnose them as disuse syndrome. This class is really going to be focusing on actual diagnoses and risk for diagnoses. Health promotion and syndrome are going to come into play once you get into med-surg and outpatient. All right, next slide. So we are going to be talking about how this is broken down. You do not need to reinvent the wheel. You don't need to start over from scratch. I want you to use your NANDA textbook. After you assess your patient and figure out what you are concerned about, go through this list and select one. So we are going to build a NANDA diagnosis for our flat John that we've been looking at. Remember, we have to have a couple of pieces, so we need to have our nursing diagnosis. This is going to be our problem. This comes straight from the list, straight from out of the textbook. And then we have our related factor. This is our subjective data. This is our, might be lies, I don't know. It is related, right? It isn't necessarily evidence, it's related to the NANDA. So with Flat John, we remember he was closing his eyes. We decided he maybe had some pain, right? Acute pain. Maybe he's sleeping. Maybe he's in pain. We don't really know. We want to plug it in. Let's see if I can pause this recording real quick. All right, so we are going to get back to this real quick. Let's see if I can, farts. All right, sorry, I'm trying to figure out how to use the pen on this thing so I can actually demonstrate to y'all and present at the same time, but it's kind of tricky. Oh, I already tried that. All right, so we are going to go ahead and move on. So we're writing our nursing diagnoses for Flat John, right? So He's closing his eyes. He looked a little bit pained. We're not really sure what's going on. So we're going to plug in that subjective data. That's going to be our related to information. And then we have our as evidenced by. This is our observed condition. This is your objective data, your assessment data. We actually know this is happening, right? So what do we know? We used our FACES scale on Flat John. We gave him about a 6, I believe, if I remember correctly. So this is our Flat John. So we're going to give him a nursing diagnosis of acute pain related to closed eyes as evidenced by FACES scale of 6 out of 10. And that would be an example of a NANDA nursing diagnosis for Flat John. All right, this slide is if you need to take a break, but seeing as how we just got started, I kind of doubt that. You can pause it if you want. All right, so we're going to move on to our plan because remember, we're working through our nursing process. So nursing process, we've already done our assessment. We've done our nursing diagnosis. Now we're going to plan. We want to come up with some goals for the patient. So what is the behavior that we do? So our goal as nurses is to leave the patient better than we found them. That's one of our entire things we're trying to focus on is when a patient comes in, we want them to leave us better than we found them. That's the difference between a crappy nurse and a good nurse, is whether or not they come out better on the other end. Our goals are going to be the main behavior behind planning. So we are going to set a goal for Flat John, and we want to follow a SMART goal. That is the format we want to use. So our goals should be specific. They should be measurable, attainable, relevant, and timed. And we are going to go off of Maslow's hierarchy whenever we're going to go off of plan something for the patient. So patients are going to complain of multiple things, right? They're always going to have multiple things that they're upset about. How we prioritize these goals is through using Maslow's hierarchy of needs. So the hospital is usually physiological and safety needs. That's really what we're focusing on. Physiological are going to be those actual diagnoses. Safety are going to be the risk for. And then the top 3 levels are going to be our health promotion diagnoses. So we're going to try to come up with a SMART goal for Flat John. Maybe we could have the patient would decrease his pain level to a 3 out of 10. And we want it to be within an hour of receiving pain medication. So it's specific. It's saying what we want the pain level to be. It's measurable. We're using the pain scale. It is attainable. I'm not trying to get him all the way from a 6 to a 0. It's relevant because he's coming in with acute pain and it's timed. I want this to happen within an hour. That would be an example of a SMART goal for Flat John. When we are planning and prioritizing, a lot of what we're doing is prioritizing. So we need to be paying attention to emergent needs of the patient first and do our ABCs. If we're doing CPR, we don't want to stop in order to write a goal for a patient. Do the CPR, act, intervene for your patient. And then once they're stable, now we can move on to our intermediate goals. These are going to be non-life threatening. This is usually why they came to the hospital. This is going to be the first 2 levels of that Maslow's hierarchy. Our low prioritization are going to be the top 3 levels of Maslow's. These are going to be affecting their future well-being, but they're not really necessarily affecting them right now. These are health promotion. Most of my lens is hospital-based. If you're working outpatient, then this prioritization might be very different. All of these are going to change as the patient's condition changes. So we're going to go from year to year. We're going to go from month to month. We do have an outpatient scope that we are focusing in on here, as well as an inpatient scope. So typically when we're inpatient, this is day to day, this is shift to shift. This is our timing that we're looking at. When are we going to measure the outcome of that goal? That's really what we're looking at here. So when do we want to have achieved the goal by? In nursing school, usually, again, this is day to day or shift to shift. And the reason I want you to be doing this is so that you reevaluate the goals. At the end of each shift, at the end of your clinical shift, you can reevaluate the goals that you set for the patient. When we're in outpatient settings, a lot of times this is year to year, this is month to month, these are much longer. And then this is going to change as your patient's condition changes too. All right, so our role of the patient in the plan creation. This really matters. We can't just sit at the desk and make the goals for people. We need to actually partner with our patients to set a realistic goal. Is the patient actually capable of doing the things that make the things in order to make the goal realistic. For example, if we have that patient who's been smoking for 20 years, smoking cessation in the next month isn't going to be realistic. Also, we need to make sure we're including the family members in the goal setting. Maybe the loved one is the primary caregiver and they're the ones that are going to be able to make all this happen. So we need to make sure that the goals are actually going to be a priority for them too. So remember, as nurses, one of our roles is to act as a patient advocate. So we want to get the patients interested in what we're interested in. So in our setting, what is our lane? Where do we need help? Who else is in our care team that we need to get help from in order to achieve the goals for our patient? For example, if we have a patient who is in there and they are using crutches every day, but they're really struggling to get up and down, maybe we need to call in physical therapists. Maybe we called in that dependent care and called in another member of the team and advocated for the patient by getting more resources for them. For the patients to be able to participate in this goal setting, they need to be alert and they need to have some degree of independence in completing some activities of daily living, maybe some problem solving, decision making. We also need them to understand the priority problems and have a willingness or motivation to resolve those issues. Remember to involve the patient in all of this so that we can promote his independence as much as possible and get him actually invested in all of this. All right, so we're going to come up with a plan for Flat John, right? Maybe our plan is lowered pain level. Remember, these are your SMART goals that we talked about. Implementation. This is the meat of nursing care. 90% of what we do as nurses is implementing. Those practice nurses, they went through those first steps and, maybe they did all of that in the first 2 hours of their shift. As a novice nurse, I expect this to take up maybe even 50% of your time while you're in the clinical setting. And that's okay. It is 100% okay to need time to learn how to do these skills effectively and efficiently. That's why you're in nursing school. All right, so when we're implementing, remember, red are things that you need to know, need to pay attention to. So when we implement, what are you going to do to achieve your goal? How are you going to leave your patient better than you found them? What actions are you going to take? We have two different types of interventions we can do. We can do independent nursing interventions and dependent or collaborative nursing interventions. Remember, nurses have their own scope of practice. This is independent from other providers. We don't need an order to do these. So these are actions that we can take without the support or permission of other team members. We have our own scope of practice that's completely independent from physicians, providers, pharmacists, all that type of thing. Our dependent or collaborative nursing independence are going to be something that require the support of other healthcare members. So this is going to be the ones that we are enacting them. Maybe we are triggering an action to make them happen, but we need help for these to actually occur. So this is maybe our patient has a broken bone and we need an x-ray. So we can talk to the physician, get an order for an x-ray, but we can't do that on our own. Maybe our patient needs a respiratory therapist. This kind of depends on the setting in terms of what we are going to do versus a respiratory therapist is going to do. In an urban center with lots of respiratory therapists, they a lot of times are going to administer nebulizer treatments. However, if you're in a rural setting where they don't really have a whole lot of RTs, you might be the one doing that. For the pharmacist, maybe we need help changing the formulary of a drug. Maybe the patient has a hard time swallowing pills. This is a really large pill, and we have a liquid formulary we could give that would be more effective for the patient. So we can call up the pharmacist and have them change that because that's within their scope of practice. All right, moving on with our implementation. Keep in mind that we need to enlist the help of the whole team. Oftentimes, there's too much work to get it all done on our own. So we need to delegate in order to get help. A couple of guidelines surrounding delegation. Does it require assessment? If yes, if it requires assessment, it cannot be delegated. This is one step of the nursing process this is step one of the nursing process. We cannot delegate the first step. Also, reevaluation is equal to assessment. Therefore, it cannot be delegated either. So if it requires a nurse, we can use another nurse. So equal scope of practice means we can have equal help. That's really what we're getting at with this. So if we have another nurse who is available, we can ask them for equal levels of help. They can go in and assess the patient. They can reassess a patient. They can do that type of thing for us because they have an equal scope of practice. CNAs have a different scope of practice, and therefore they have a different level of help that they can do. They can assist with gathering objective data from patients, but they are limited by the practice of assessment. That's really what we are seeing here for recording. All right. Sorry, I had to readjust my screen for a second. All right, so we're talking about delegating. CNAs are limited by assessment, so they can't do the practice of assessment. This means that we cannot have them interpret data. We can't have them do reassessments either. Another thing I want you to keep in mind, so LPNs are trained to recognize the difference between normal and abnormal, but not to actually intervene to correct something that is abnormal. So LPNs are able to assess, but limited in the scope. Their limit of scope is in recognition of abnormal, and then reporting abnormal findings and acting on that. For a while there, we're seeing LPNs really phased out of nursing practice, but they are really starting to come back. Rural and long-term care are using more and more LPNs because we don't have enough nurses that are being trained. So whenever you're implementing and you're trying to delegate and getting help, you have to remember scope of practice and what the other person can and can't do. All right, so this is the brain fight, right? Do we follow physician orders? Yes and no are both correct. There is absolutely nothing within our national or local scope of practice that says we have to do anything that a doctor tells us to do. We have our own independent scope of practice that does not include physicians. So why do we follow doctors' orders? Our goal as nurses is to move our patients toward a greater sense of well-being. We want to leave them better than we found them. If we can recognize that a medication will improve the well-being of our patient, or if diagnostic imaging will help us achieve this, then we want to do that. But we are not obliged. We don't have to do that thing. Part of what we do as nurses is we are patient advocates. Remember those core concept of nursing in your graduate competencies. So we are being patient advocates. Well, what does that mean? What does it mean to be a patient advocate? This means that we are... sometimes people think of this as defending a patient. It's kind of a bad way to think of this. We really want to think of it as promoting the best interests of our patient. Our entire goal is to promote the well-being of the patient. If we see something in the chart that the doctor or provider has ordered that doesn't make any sense, ask for clarification. That is advocacy. Sometimes that means not doing the task. Sometimes we just need to understand why it's happening, why they've ordered that. So what are we doing when we review physician orders? We are questioning whether or not it makes sense. Is this going to improve the well-being of the patient? If not, or if we don't know, we need to seek order clarification. We're going to watch this video real quick. You know what? I have a feeling that's not going to work for you because I'm only sharing this tab. So never mind. We can review that later. All right, we are going to continue on here. Sorry, don't know what happened. All right, here we go. So moving on, we are now implementing. So we are going to implement this into practice. Depending on where you work, you may or may not encounter these. These are guidelines for implementation. These are called clinical pathways. They are often multidisciplinary plans for treatment. These are guidelines for implementation so that we build in predictability for individual patient presentation. These are most frequently used in rural healthcare settings and in the emergency department in order to move care forward. So we don't necessarily always have a physician available, but what we really need to do is move the care forward. So here's how this works. We have a patient come into the emergency department. We need to evaluate them. We evaluate them. We notice that they have some chest pain. We don't know if they're having an MI, if they have possible ischemia, or if they have non-ischemia. So when we do this, and we notice that it's unstable angina, or they have acute myocardial infarction, we're automatically going to admit them. If they have possible ischemia, we are going to see whether or not they can walk, or if they are unable to walk. That'll put them either into a 6-hour or 12-hour observation. And then we're just going to follow this all the way down to its end point and determine whether or not they need to be admitted or further observation, or if they can be discharged home. All right, so now we are going to implement what are we going to think about some independent interventions for flat John. So these are things that we don't have to have an order for, remember? Think about non-pharmacological pain reduction methods. So we can use aromatherapy, maybe we can use music therapy, maybe we can use a low stimulation environment, maybe we can get him an ice pack or do some deep breathing exercises. These are all examples of independent interventions we could do for flat John. For dependent interventions, maybe we want to get an order for a pain medication that we can get. And that would be an example of when we need a provider to write an order to get something for this patient. All right, now we are going to move on to evaluation. So what we need, what we're looking at the results of the interventions. So how well did it work? We need to know if each individual intervention was successful in achieving the goals. So we're comparing what actually happened, what we actually achieved with what actually happened. So what was our goal versus what actually was the outcome? And then what behavior do we need to do? What do we need to do in order to achieve what we want? We need to reassess. Remember, this is a song that never ends. So how do we reevaluate teaching? We observe them. We observe change. We see them doing something that we ask them to do. We teach back. We demonstrate. We want to see them independently as much as possible, putting these interventions into practice. When we evaluate, we also want to consider, was there anything that we did wrong or where we were off base about? Maybe the aromatherapy gave the patient a migraine. Maybe something we did was ineffective. What we are really doing here is using self-reflection to identify errors. Were we misinterpreting the symptoms? Is there something that we implemented incorrectly? So both look at the thing you are doing and how you are doing it when you are evaluating. An example here for evaluation. So what evidence is there for success? Was our SMART goal achieved? The pain level is down. What assessment, objective or subjective, tells you that intervention really worked? So for flat John, maybe his facial expressions have changed. Maybe he's reporting a better pain level. Or was the goal not achieved? If the goal was not achieved, what did we learn? This intervention was not effective. Does that mean we need to throw out that intervention entirely? No, but it didn't work for this individual. So what could we do differently? And this is where the nursing process starts over again. All right, flat John, you fixed him. And he's 10 years younger. Yay. What evidence do we have that we fixed flat John? His posture. He's standing up right now. His face. He looks excited and happy. He's giving you a thumbs up. His color looks better. Those types of things are things that we can evaluate for our patient. And now we start over again. So again, song that never ends. When you do your evaluation, this is another time that you are assessing, which cues you in to repeat the nursing process. That's really what you're doing here. When you're evaluating at the end of the shift, you're going to start the next nurse off at the beginning of their assessment. That's the jump start point, that handoff. Go ahead and take a break if you need one, and then we'll come back and go through the clinical judgment model. So this is the clinical judgment model. This is how we do the nursing process. So this is super practical. So how do we stop thinking like a human and start thinking like a nurse? Remember, this is that brain fight. This is what I want you to do when you show up to clinicals. This is the entire point of nursing school, is to learn how we do the nursing process. So clinical judgment is how we do it. First, we are going to recognize cues. If you see up at the top of the screen here, this is the pathway we're going to be taking. So we're going to recognize cues. This is gathering all of the data, all of it. So what is the raw data that's available? This is our subjective and objective data. We need to recognize that we need data and know what to do for our patients. So we're getting all of that. Now we're going to group it into relevant, we're going to organize it into relevant groups. This is our level of evidence. How do we start to organize a huge pile of data? Remember, one piece of data is kind of curious, makes you think. Two pieces of data, well, that's interesting. Three pieces of data, now we have compelling evidence. So how do we get to the three pieces of evidence? We want to achieve that. So we have active data. We have our screening examination. This is our head to toe. This is our patient interview. So we're asking them everything about why they are seeking healthcare. Patient updates. This is your report. This is the bedside handoff. Bedside handover is where you start the nursing process. If you miss the bedside report, you miss the opportunity to fully assess your patient. Remember, you have to assess your patient. This is not analyzing computers. Get in the room, look at your patient, ask questions, touch the patient, figure it out. And then we have our passive data. This is our lab results, our diagnostic results, our medication prescription. This is information that we can get from mining the chart. And then we are going to move on to our professional set of information. This is just recapping everything we've been going over. So our one level of our one data point, that's curious. 2 data points. Well, that's interesting. 3 data points. Now we have compelling evidence. Now we want to do something. So next we want to analyze cues. So what we are doing here is we're taking a massive body of data. We're seeing what problems I am compelled to know are there. This is detective work. What have I discovered is wrong with my patient? And what are my 3 pieces of evidence to support this? Based off of your evidence, what are the most likely problems? And then what can be excluded? What needs to remain included? Once we know we have our problem, what can we exclude? So if our patient has a fever, what data do we expect? Maybe our patient also complains that their left knee hurts. What types of data do we expect if we have a fever in a patient? Well, I expect their heart rate to be high. I expect their temperature to be high. Maybe they are sweating. Maybe their heart rate and respiratory rate are a little bit elevated. And then their left knee also hurts. So what piece of data do we not care about? The knee. What are we going to keep? We're going to keep the 3 data points that make us compelled. And then what are we going to do with it at the end of the day? We're going to evaluate the outcomes, right? So what do we want to know about the 3 pieces of data after we have evaluated? Before I move on, is any additional information needed to increase confidence? Patients are complex when they are present, especially as they get older and have multiple comorbidities. Sometimes we need more pieces of data. So any critical care environment, 3 data points may just be the start. We might need to get more data through our focus exams to prove that this really is the problem and you have successfully isolated the issue. For example, if we have a fever, maybe we want to rule out sepsis versus cardiovascular collapse. So we'll need to do a focus exam. This is extremely important in order to gather more data. So we need more data points. We're going to do those focus examinations. And then once we have those 3 pieces of data, when we reevaluate and we evaluate our outcomes, we're looking at whether or not our patient is the same, if they are better or worse. All right, so now we're going to prioritize our hypotheses. What are hypotheses? These are our nursing diagnoses. We are going to rank them. They're going to be either urgent, immediate, or low. If we're doing compressions, don't stop to do your nursing diagnoses. Just do the CPR, right? And then how do we prioritize intermediate nursing diagnoses? This is going to be 90% of nursing. So what tools do we have to prioritize? We have Maslow's. We are going to think about our first level. These are going to be our actual problems, right? This is patient stated. We're looking at the patient stated severity, how urgent it is to them, how much it matters to them. These are our actual problems. Second, here is going to be our safety issues. And then our third priority is going to be health promotion. So patient needs and desires are, there's been a long-standing thought that patient needs and desires always come first. This is the customer is always right mentality. However, if the patient was truly right, we probably wouldn't be meeting each other. So no, their desires don't necessarily come first. But if we want to achieve anything, we can't just demand it of the patient. We need to work with them to make sure our plans are in line with what they want to achieve. So our fever patient, if we only focus on the fever, but not on the knee pain when they are very concerned about the knee pain, we haven't achieved anything. We need to balance the patient's priorities with what we know are the medical nurse priorities. So what is the patient's goal for the day? The patient's goal frequently is to sleep. Maybe they just want to rest or to eat. That has nothing to do with what is medically wrong with them. But we as nurses need to advocate for both needs. Always listen to your patient and ask them what is important to them. All right, goal writing. So this is, we talked about this. Sorry. Forgot about my animations. All right, so generating solutions. This is goal writing. These are our SMART goals. So based off of the most pressing problems, how can we make the patient better than we are now? What are the priority actions that need to be taken? So this is our specific, our measurable, our attainable, our relevant, and timed goals. We are all not just writing goals here. We are also performing interventions. So what are you going to do first? With the fever patient, remember Maslow's hierarchy. So treat the fever first, give them some acetaminophen to get their temperature down. Now we are going to see if the acetaminophen also worked on their knee pain, and then we can move on from there. When we take action, this is doing the task. This is what we are spending most of our day doing as practicing nurses. For those experiencing nurses, recognizing cues, analyzing hypotheses, and solutions are generally done within the first couple hours of the shift. The remainder of your shift is spent taking action. In training, you may spend half of your day in these first steps because you do not have the practice to be able to do it fluidly. That's okay. That's the point of nursing school. Nursing practice is not pass-fail. You are going to come up with interventions. You're going to carry them out on people. And when they fail, that's okay. You're going to do things wrong. However, unfortunately, nursing school is pass-fail. You either pass it or you don't. But there's nothing wrong with an action that doesn't achieve what you hoped it would. As far as you in nursing school, I want you to know that you are mentally safe to be slow and bad at nursing. This is why this is foundations. You are not an expert nurse right now. You are a novice. So while you are in nursing school, the entire point is for you to be safe and feel safe being slow at this process and going through these steps one by one until you learn and make it fluid and become a practiced nurse. All right, so now we're going to evaluate our outcomes. So this is the same as the evaluation phase of the nursing process. What are we doing here? We are reevaluating in the context of what? The goals that we outlined for their care. What was the patient's response? So what clinical data, that's your reassessment, do we have to show that something changed? How are they now compared to how were they before? How did the patient respond to the thing you did to make them better? When you're gauging patient response, you always want to focus on the trajectory of the patient. So is the patient better, worse, or the same? What data do we have on how the patient is now data on how the patient is now without context doesn't really matter, right? So if the patient had a fever, they were 101, they were sweating and shaking, but now their temperature is 99.7. They're not shaking anymore. They're not sweating anymore. This tells the story of what you did. And last, we want to look at what problem may still be present. This is continuing the nursing cycle. This is clinical judgment. Remembering that the clinical judgment model is also the song that never ends. It cues us to start back over. When we give that handoff, we are trying to tee the next nurse up for their nursing process. We need to evaluate what barriers there are. So why were you not successful? Maybe you need additional resources that need to be activated. Did we do an independent intervention, but that wasn't enough? Maybe we got them in the chair a few times, but they need physical therapy to get them a walker, walk them around in the hospital and help them be more independent, etc. This is where we start the nursing process over again. So our nursing care plans, this is our NANDA. What are they and why do we do them? So that's what we're going to talk about. You've heard about care plans. You have heard that they're terrible. You've heard that they're awful. We hate them. They take up so much time. They're a waste of our practice. We're never going to use these, blah, 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 blah. However, when you are new at nursing, what nursing care plans do is help you to organize your thoughts like a nurse organizes your thoughts. This is how you do nursing. If you can fill out a care plan, you can provide expert level care to that patient for one shift. All right, so all of these are going to be components that go into our clinical practice to make up how we do nursing. So we are going to include our critical thinking, we're going to include our nursing process, and our clinical judgment. These are all aspects of our nursing practice. All right, I'm going to pause this recording for a moment. All right, so the rest of this we are actually going to do in class together because I want you to be able to see how we do a nursing care plan together. I want to kind of walk you through that. When you're thinking about why we do this job, why we do nursing diagnoses, why we do care plans, why we go through this process, there's really only one reason. It's for the well-being of our patient, because this might be your patient one day. Right? So this quarter, you're going to have the most stable patients you're ever going to treat. However, this is what you may be working towards. We might be working towards this patient on the ventilator in the ICU, or maybe we're working towards this patient where we have a little NICU baby who is on lots of tubes and pressors, and they need lots of levels of care, right? So this is why we do what we do. All right, guys, thank you for your patience with this recording. We will go over more about nursing diagnoses in class tomorrow when I see you in person and kind of review all of this a little bit. And if you have any questions, I'm happy to answer them then.